Good day, everyone. My name is Onowori Victor. I am a neurology applicant and I will be doing the Cheng's comprehensive review in clinical neurology. We've done questions 1 to 5 of chapter 2, which is vascular neurology, and right now we are going to be doing questions 6 to 10. I got a feedback from the previous episodes, and thank goodness for that feedback. I was told that I use a lot of fillers, including so and now. I will try as much as possible to limit my usage of those words. So, in place of those words, I will be pausing, and I think that is actually a better way for me to regulate the amount of fillers I use. So, that being said, let's begin. We have question 6. A 51-year-old man presents with ataxia. An MRI was obtained and is shown in figure 2.2. Which of the following will most likely result from this injury? Let's take a look at this MRI. So this is an axial diffusion weighted MRI. Now back to our options. A. Vertigo, nystagmus, and right-sided ptosis and meiosis. B. Vertical gaze impairment. C. Right third and sixth cranial nerve palsy. D. Hemisensory loss to pain and temperature on the left side of the face. D. Hemisensory loss to pain and temperature on the right side of the body. If we go back to this MRI, what do we see? So we see DWI axial view at the level of the medulla. Why the medulla? We can see something that looks like a boot, but the top part is not big, so it's like it's coning down, it's narrowing down. We can also see something that looks like the pyramidal tract over there. This is classical for the medulla. Now in this image, we can see that there is an infarct somewhere around this region of the medulla. This is at the lateral part of the medulla. We also have an infarct, a very wide infarct at the level of the right part of the cerebellum. To put this in a neurologist word, this MRI shows restricted diffusion in the right lateral medulla and the cerebellum, and we call this lateral medullary syndrome or Wallenberg syndrome. Now, a Wallenberg syndrome or a lateral medullary syndrome is caused by an occlusion of pica. Pica is posterior inferior cerebellar artery, and this is often associated with occlusion of the vertebral artery. It involves the vestibular nuclei, which will cause vertigo, nystagmus, nausea, and vomiting. Also, you may have affectation of the descending tract and nucleus of the fifth cranial nerve, that's your trigeminal nerve, and this may produce impaired sensation on the ipsilateral hemiface. You may also have affectation of the spinothalamic tract, and this will produce loss of sensation to pain and temperature on the contralateral hemibody. You may also have affectation of the spinothalamic tract, and this may produce loss of sensation to pain and temperature in the contralateral hemibody. You may also have sympathetic tract involvement, and this may manifest as ipsilateral Horner syndrome, showing symptoms including ptosis, meiosis, and anhidrosis. Also, fibers of the ninth and the 10th cranial nerves may be affected, and this may present with hoarseness of voice, dysphagia, ipsilateral paralysis of the palate due to the 10th cranial nerve involvement, and the vocal cord. You may also have decrease in gag reflex. Now, due to the cerebellar involvement, the cerebellum and the cerebellar tracts, you may have ipsilateral ataxia, and due to the affectation of the nucleus of the tractus solitarius, you may have loss of this sensation. Back to our question. Options A, vertigo, which is correct. Nystagmus, which is also correct. Right-sided ptosis and meiosis, that is Horner syndrome on the ipsilateral side, which is correct because the lesion is in the right lateral medulla and the right cerebellum. So vertical gaze impairment, let's look at B. B is obviously wrong. And why is B wrong? Because vertical gaze impairment is seen in midbrain lesions. Right third and sixth cranial nerve palsy. So third cranial nerve palsy will be seen in a midbrain lesion, and a sixth cranial nerve palsy will be seen in the pontine lesion. Hemisensory loss of pain and temperature on the left side of the face. Now that is wrong. This will actually cause hemisensory loss of pain and temperature not on the left spot, on the right side of the face. And why on the right side of the face? Like we said, the trigeminal nuclei is located somewhere along that tract. That's cranial nerve number 5. Remember, the trigeminal nerve actually has its main nuclei in the pons, but then it also has extensions which are cut across the entire brain stem. So you have some of the sensory nuclei in the midbrain and some of the sensory nuclei in the medulla. Then hemisensory loss to pain and temperature on the right side of the body, that's false, and that's because of the fact that this lesion is on the right and we've not had the crossing yet. So usually it will be a contralateral loss of pain and temperature. So our answer will be options A, which is vertigo, nystagmus, and right-sided ptosis. For our next question, we have question number 7. A 34-year-old man presents with vertigo and neck pain after riding a very wild roller coaster. The examination the examination demonstrates anisocoria with mild ptosis on the left side, nystagmus, reduced sensation on the left side of the face, and left-sided ataxia. Which of the following is the best diagnostic test to evaluate the cause of this condition? So clearly, this patient has symptoms that are pointing towards Horner syndrome. Look at the anisocoria and the mild ptosis on the left side, and the reduced sensation on the left side of the face is just screaming Horner syndrome. And the left-sided ataxia and the vertigo, this is pointing towards lateral medullary syndrome. So this patient, most likely in the presence of the neck pain and the history of riding a very wild roller coaster, we can think of a vertebral artery dissection, a left vertebral artery dissection. It is important for us to note that the most common site of a vertebral artery dissection is at the level of C1 to C2. This is where the artery is very mobile as it leaves the transverse foramina to enter into the cranium. Now that we've had our diagnosis, let's think about the tests to use to confirm this diagnosis. Now, the gold standard test is actually a catheter angiogram. This will help us to evaluate the cervical cerebral arteries, which will demonstrate the narrowing of the vessel. It will also demonstrate the extension of the dissection, if any. It will show us the intimal flap. It will show us whether there's a double lumen. But the problem with the catheter angiogram is the fact that it is a very invasive test and it has potential risks. And one of the risks is that it can actually cause a dissection. And another risk is that it can worsen an existing dissection. Right now, we have a test that helps us to replace a catheter angiogram, and that is a CT angiogram or an MRA with contrast. And these are very helpful tests and they help us to actually see an arterial dissection. In fact, right now they've replaced the catheter angiogram for diagnosis of dissection of the cervical arteries. Let's go back to our option. The first option is carotid ultrasound scan. Ultrasound scan is a non-invasive test and it's helpful and useful in initial assessments. However, a dissection may not be visualized and ultrasound scan may not be able to tell us the extent of a dissection, especially when it comes to the vertebral arteries. They are really hidden and they are not completely visualized with ultrasonography. Our next option is the transcranial Doppler ultrasound scan or ultrasonography. Transcranial Doppler ultrasound scan will not give us a direct visualization of the dissection. In fact, it's not really helpful. Next option here is the transthoracic echo with bubble study. Again, this is not a useful test. In fact, it is not indicated for the evaluation of vessel dissection. We've said catheter angiogram of the cervicocerebral arteries is true. That's the gold standard test. So let's look at option E, time of flight MRA of the circle of Willis. An MRA with time of flight sequence may be helpful to assess the flow at the site of the dissection. However, it does not provide information about the vessel wall. And whenever you are evaluating for a possible vertebral artery dissection, if you limit your evaluation to the circle of Willis, you may actually mix an important or a potential dissection in the cervical portions of the vessel. Let's briefly talk about time of flight. I think we should just do that just for completion's sake. So the time of flight MRI is a type of MRA technique. MRA stands for magnetic resonance angiography, which is used to visualize blood vessels, especially arteries, without the use of contrast dye. Basically, we create detailed image of the flow of blood, typically in the arteries of the brain, the neck, or spine. Now, the time of flight actually is the fact that when blood moves, it has a different magnetic property than stationary tissues, and this allows the scanner to highlight these vessels. Stationary tissues like the brain tissue are repeatedly exposed to radio frequency pulses, and this saturates their signals. Fresh, unsaturated blood that is flowing into the images give off stronger signals because it hasn't been saturated yet. So the MRA collects the strong signals from flowing blood and constructs bright images of blood vessels. The advantage is that it is no contrast dye is needed. It is useful for people who have kidney issues or allergies. It is great for detecting narrowing blockages or aneurysm, and is actually widely used for stroke cerebrovascular disease evaluation. Now, it has certain limitations, which includes the fact that when blood flow is very slow or turbulent, this may cause loss of signals, and sometimes it can actually overestimate stenosis. Motion artifacts can also reduce the image clarity. In conclusion, for question 7, options D is the answer. I think we have hit the 11 minutes mark. In fact, we're about to hit the 12 minutes mark. And in order to make sure that this video does not become something very boring and long, I'll just call it a day here. See you in the next episode.